So I'm prevailed upon by my team to explore some of this. We're increasingly interested in history at Nuffield. We think, in contrast to other countries, the NHS has not got a good historical memory. We might remember, some of you might remember Clive Smee, who was a regular attender at this event, who wrote this very interesting book on speaking truth to power. It's a shame he's not here. He would have made a great contribution to this. But thinking back on him, I thought it was a good time to look at what have we learnt and how might we codify it. But it's quite interesting that we often talk about failure, so I thought we ought to start with some successes, and I asked my Twitter followers what they thought had been successful. They're in the same bubble as me, so they obviously came up with a list that I deeply approve of. There are quite a few more. There's also some nominations of sort of more local, what you might call street-level policy, stroke centralisation, for example. Daily ward rounding even was nominated. It's notable that most of these are relatively focused. They'd all got a pretty good evidence base behind them, and where they didn't, they at least had a good theory to underpin them. And while the implementation of them was often sometimes quite complex, none of them were particularly complex pieces of policy. By contrast, the policy, actually the other notable thing is most of them are not in the last 10 years, you might notice, which we might draw some conclusions from. And quite a few of the public health lobby had probably most of them, interestingly. So the successes, the biggest public policy disaster, bar one of the last 20 years probably, was Andrew Lansley's reforms. I'm meeting a delegation from the Bosnian Ministry of Health who are coming to meet him to learn how to do healthcare reform. I'm hoping to meet them before, so that... The other noticeable thing about this is that quite a few of these have got acronyms associated with them. I don't quite know what you might conclude from this, but many of them are also the enthusiasms of what you might call policy entrepreneurs, people with a plan. They're also notably really complex. The other thing I discovered is that the closer you are to an issue, the more likely you are to think it's the biggest disaster. So dentists thought the dental contract was very bad. Junior doctors weren't keen on modernising medical careers. You probably got your own version of those. The most disappointing actually were the things that we had left undone rather than the things that we had done. So our failure to plan the workforce, the serial failure to reform social care, and the mysterious but frequently cited failure to deal with culture. So let's try and develop some analysis about what underpins what's going on here. And let's start with the design of policy itself. So we've had a theory of policy making which is a sort of like a rational choice model, but pretty much discredited now and not really much held to. We now acknowledge the bounded rationality in which you don't consider all of the options, and we acknowledge our limited sort of cognitive space to make decisions. We won't optimize so much as satisfy us. The problem with overly theoretical models, like Andrew Lansley's one, which was drawn, if you remember, from the privatisation of the utility industry, is that the model may not be a very good map of the territory. In fact, in his particular case, it was a deeply misleading model for how to think about things. So I like the phrase, all models are flawed, but some are useful. And the most flawed ones, I think, are those where you're relying on theory and evidence, which has been oversimplified, distorted, or in Andrew Lansley's case, just wrong, or perhaps more fairly, transplanted from a different context in which it didn't really work. And you may remember that having designed his sort of almost axiomatic set of policies in 2006, he then sort of stepped back and went, my work is done. And despite the near collapse of world capitalism, he didn't, and the introduction of austerity, he made no attempt to adapt his model to the new circumstances. So context, that gives us a clue that in this territory, context really matters. I was struck that Simon Stevens used a similar quote to this. It's from Karl Marx. I think he knew he was quoting Marx. It was an interesting reference. So context, and in particular path dependency, the way that previous choices that we've made constrain the choices that we can now make, do have a really important influence. And having due regard for that and not trying to break away too much from that, probably, for example, explains the success of Dutch healthcare reform over the last 20 years, where despite massive changes in government and political swings, there has been a broad consensus on the underlying theory of change, the overall direction of what's of where we're going, and a good understanding of where we've come from. And the neglect of this, thinking about context and history, often leads to ideas being resuscitated or borrowed from ideas that are just not very helpful. It's also, by the way, very useful when you do go and borrow an idea to check that it is actually working in the way that its proponents tell you. I'm sure you've all been to visit sites of good practice examples from the HSJ, only to arrive and to find they're not actually doing what they said they were doing, or they've stopped doing it because it didn't work. If you simplify and ignore things, you can then, however, it does become much easier to write policy, and we end up with a sort of cookie-cutter policy which works on average and therefore nowhere. We design by simplifying and departing from an understanding of context and where we've been. So. A third issue relates to sort of poor conceptualization of the problem. Often common examples here would include sort of faulty logic. We've all seen logic models where the arrows from the boxes of causation don't seem to quite work when they connect to the outputs that are being expected. Sometimes we've had a tendency to conceptualize problems as being about failures of incentives and structures and rules, when actually they're probably more about culture, behaviour, and relationships, and therefore actually somewhat out of reach of most policy instruments, except to the extent that they can do harm. A third problem here is assuming that the signals that you're sending, whether that's through prices, incentives or policy instructions, are actually going to be interpreted and responded to in the way that you intended. You may well be dealing with rational people at the end of your policy process, but they may be optimizing, there may be other goals than the ones you think you're pursuing, or they may have to trade off goals in ways that frustrate your policy. So the voltage drop from sending out your policy to it being received can be very, very significant. A tempting response to the problems of context and complexity and heterogeneity, as I said earlier, is to simplify the issue. And a particular way of doing this that's quite hazardous is to use your personal experience as a policymaker to inform policy, which is why I think so much primary care policy over the last 15 years appears to have been designed to meet the needs of middle-aged people who commute to SW1, and as therefore tended to over-stress access and late night opening over continuity of care, for example. Another problem is to sort of design for a subset, or your idea of a subset of the group. So I think the consultant contract in 2004 appeared to be based on the premise that those consultants that weren't playing golf were doing private practice, and we therefore got a very sort of mechanistic, Taylorist type of set of policies for the consultant contract, which I think could go on our list of not great policy successes there, because of course the majority didn't fit into that category at all. The other problem is a sort of framing of the issue in a way that is sort of contested. In a way that suits the policymakers, but the problem being that they're often contested. So, for example, we need to rationalise small hospitals because of issues of safety and critical mass. And when you then go and actually look at the evidence, as people who've been to a previous summit will know from work that my colleague Luella Vaughan and others have done, that the evidence is often contested. The other stakeholders have different ways of framing that problem. They may actually value other criteria over the ones that you're using. For example, they may travel times more highly than you do as a policymaker, and actually more commonly they just don't believe you. And one of the things we might look at later is the growing mistrust of experts and the way that they frame the policy questions that they're looking at. Problems with objective setting next. The list here is the objectives of the original payment by results system, and the sharp-eyed of you might notice that there are two objectives on this list that are directly contradictory to each other. One is that this policy instrument will increase admission to hospital, and the other for elective, and the other is it will decrease admission to hospital for emergency, and it's the same instrument. The other noticeable thing about this, if we were put this next to the objectives of DRG type payment systems in other European countries, they would generally have probably two objectives. Not this long list. And this list grew over time through a sort of mission creep, but also by a process in which sort of policy entrepreneurs see a successful policy and then try and attach their policy to that one. So you try and get QOF points, or you try and get into the planning guidance, or you try and get a sequin, and that becomes the objective. And when you report your impact as a lobbyist, for example, for a disease group, it's measured by how far you've managed to hang policies like a Christmas tree ornaments over other people's policies, which ends up with this problem of contradiction and indeed too many objectives, which of course massively gets in the way of implementation. This sort of competing objective problem might also explain why we can't really settle on the right size for commissioning organisations. I mean, not just because we're very unclear on what commissioning actually is and haven't really worked it out over the last 20 years, I think, but also if it's too small, it can't deal with hospitals. If it's too big, it can't talk to primary care. We can't seem to cope with a degree of plurality in that area, which is always puzzled me slightly. Let's talk about the poor design process. In 2002, Alan Milburn made a speech in which he said there are going to be radical plans to allow the private sector, charities and universities to take over management of England's failing hospitals. And the idea was called franchising. And I remember vividly Neil Mackay, the then deputy CEO of the NHS, coming to a meeting of chief executives and said, we just made this speech about something called franchising. Have any of you any idea what it might be about? We said, well, you're the deputy chief executive of the NHS, isn't that your job? So his job indeed was to retrofit a policy idea that had already been announced, but unfortunately Milburn had announced it in enough detail to actually close off some of the more sensible ways that you could have realised it. It's also another interesting example of Mary Dixon Woods used the phrase cargo cult quality improvement. There's also cargo cult policy in which you replicate the external appearance of something but without truly understanding the essence that actually underpins it. So there is actually something called franchising. It has got something real to it, but you've kind of hollowed it out and you've got the outward appearance of it, but you haven't got the reality. It's also a good example of a solution looking for a problem. Research by Carol Proper and others, and quite a lot of research in football of all places, suggests that poor performance is not necessarily due to poor management. And that changing the management may not have very much impact on your performance. It wasn't also clear that many of the hospitals who were failing because of poor management. It was often the system that they were embedded in. I shouldn't be too cruel to Andrew Lansley, but listening was not his strong point. So that's another hazard. We've got selective use of the evidence and ignoring findings that don't support the direction. I think we've seen in quite a lot of countries a growth in interest in policy-based evidence as opposed to evidence-based policy. So a tendency to latch on to ideas and then go and look for the evidence to support them. David Cameron and the 5,000 health visitors was an interesting example of both ignoring the evidence but also selectively using it. Ivor Crewe, in his book The Blunders of Our Government, argues a lot of this is due to the fact that scrutiny has become much less rigorous in the past. And slightly humorously, but probably quite plausibly, they cite the problem of scrutiny by PowerPoint. I don't know if those lovely slides with blue boxes on them allow you to jump over arguments that are important and ignore important things that should be talked about. So I rather like this slide. Power corrupts. PowerPoint corrupts, absolutely. And it is actually also blamed for the Challenger disaster, by the way, PowerPoint, along with the rubber rings, for obscuring what should have been talked about. The most obvious problem is short-termism around policy design is short-termism and the clamour for immediate results, and that's partly the electoral cycle. But actually, we get this even between electoral cycles because secretaries of state often change within governments and want to move things quickly, and it's quite hard to make the argument about that you need elapsed time to do all of these things. So. There's probably more things, and in the discussion we'll add to those. But there's also, once you've designed your policy, you do have to then implement it. And so quite a lot of good policies do get through the hazards I've listed, but the further problems then start to come when you try and implement it. The lack of a narrative about what you're trying to do and why you're trying to do it that really is compelling and gets people behind it, it's been a feature, that absence has been a bit of a feature of quite a lot of policy. I'm going to pick on poor old Andrew Lansley again, because I just have to share this quote with you. So he was had to rush up to the Royal College of Nursing conference because one of his junior ministers had been slow, hand-clapped or barracked or had a very hard time. So he met a select group of nurses to talk about his reforms, and he said this: "I'm sorry if what I'm setting out to do has not communicated itself." Right? It does strike me that if you're relying on a multi-layered policy to explain itself without any assistance, you've already lost. And so the failure to communicate the benefits, the case for change, and what needs to be done is surprisingly common. And you could argue that to some extent, the 5-year forward view and the long-term plan more recently have got lots of. They're way ahead of Lansley's reforms in many ways, but the lists of things to do, they're quite conceptual. They're quite abstracted from the clinical front line, and they don't really actually seem to have a particular theory of change, and that's quite common in quite a lot of places actually, so shouldn't pick on anyone. What are we trying to do? Are we trying to use markets? Are we trying to use hierarchies and management control? Are we relying on professionalism, or will telepathy see us through? Telepathy, not a hugely successful method, I think you'll find. Okay, there's a lot of big things. There's a long list from the business literature, of course, which many of you will be familiar with. We'll just perhaps pick a few. What's the role of the payer and the provider in this? And not being clear about that has often been a problem, and bits of the system have tended to fall over each other and compete for space. The time scale and optimism bias, the tendency, optimism bias is that thing where if you've ever written a revision timetable, and by lunchtime you'll have done geography and French, and by lunchtime you've put the washing on, had a little lie down, and started a bit of French. Right? That's optimism bias. It applies also to building hospitals. It's a common problem. I think one of the things that just the sheer logistics of doing some of these changes are not appreciated by the people who are designing the policies. I was talking to my colleague Rebecca Rosen about the process of just getting a pharmacist embedded in a primary care network, and just the mechanics of getting the people that you need in the room together means that you're starting to suffer from the same revision timetable problem really quite quickly, and particularly if those logistics also include people who've not really worked together, learning to work together and forming those relationships. Hard to compress that, and I really don't think that's fully understood, and you therefore get this sort of problem where you get a confusion in the minds of policymakers between having said they've got a policy and then it being implemented. I once overheard a conversation between the then Prime Minister's advisor and Secretary of State's advisor. The Prime Minister's advisor said, "Oh, we got Foundation Trust, we've got payment by results, we've got GP commissioning, we just need to let it rip." To which the Secretary of State's advisor said, "No, Julian, we've just said we've got those things. That's not the same. They're not in place." Have I given away who that was? It was some time ago. The list goes on. Inadequate resources, particularly workforce, as we know, often gets missed out. But actually, the double running, the organisational development, and the other elements of change management often get missed. We continually miss the implications in terms of workforce capital and the like. Misalignment of payment and regulation. Well, we're very familiar with the way that some of our incentives have really pointed people in the wrong direction. the problem of layers of policy, one on top of the other, that bump into each other without clearing away the mess, often gets in the way of implementation. Perhaps the most common problem, and again, we're not unique in this, although we probably, it is the case that other countries do look in wonder at the policy laboratory that we've got going on, about the number of pilots and things that we do. They also, by the way, are absolutely staggered that we don't seem to evaluate them, or we don't run them for long enough. But that's a separate problem. But the problem of how you take a pilot to scale, and all of there's a big literature from implementation science on that, which we haven't time to go into now. But again, we haven't really incorporated the lessons from that, and we're still talking the language of scaling up models which are context dependent and just rolling them out. We were commissioned to look for a standard model that you could implement in acute medicine for small hospitals. And we came to the conclusion that A, it was a bad idea to do it, but even if you could do it, it would take 50 years of selective retirement and recruitment to be able to be implemented. So there is a sort of lack of realism here in some of this. You can't just scale up one thing into a bigger system. And then I think perhaps another problem, a lot of rhetoric of the need for culture change, but many of the policies we use to do it are sort of superficial and fail to land. One element that we all sort of know about, but perhaps doesn't receive quite as much attention as it should, is that there is something special in healthcare about having a large and powerful workforce that may have a set of values and views which are not necessarily aligned with those of the policymakers. So Henry Mintzberg talks about the concrete floor that separates the clinical front line from management, in which the clinical floor know very little about what goes on above that concrete floor. And Peter Degeling, long retired now, but social anthropologist, found that if you looked at the attitudes and approaches of doctors, managers and nurses, they were very similar between different continents, with the exception of China, if I remember rightly. And here, I'll explain this graph because it's not immediately intuitively obvious to look at. So what he would say is there are differences in views about attitudes to accountability, to the extent to which it's personal versus personal and opaque versus external and transparent, and about autonomy, and about how far you ascribe to models of work which are systematized and process-driven, as opposed to more individualistic models of practice. They differ in attitudes to team, on the distribution of power, and the extent to which a clinical decision is a financial decision, and that should be thought about. And what the graph basically shows is that managers, nurses, and what he calls medical clinicians are on very different places on this graph, with unsurprisingly certain agnosticism towards the financial implications of clinical decisions amongst clinicians, and more individualistic conceptions of work, less interested in systems and processes. Managers in a slightly different place, nurses quite keen on systems and processes, much more hostile to the financial implications of. So these are really quite significant differences in where people are. Medical managers are caught often in a rather difficult no man's land between the different groups. The good news is actually over time, he found this was work that was done in the early 2000s. He repeated it again 10 years or so later, and discovered that there's been convergence. And actually, there is a little bit more. There's some good news in all of that. The other problem I think we've got is the extent to which scale and complexity really causes a problem. I've always liked this diagram. This makes distinctions between, we have on this bottom axis, the extent to which we are certain that if I do A, I get B. So we have certainty about causality, and the further we come down the x-axis, the less certain we are. And on the y-axis, we have the extent to which we have agreement on values and objectives. So if we have an area where we've got no agreement and uncertainty, no agreement on objectives and uncertainty about causality, then you end up with, are you fighting a war on drugs or are you trying to decriminalise it? If you've got high agreement and high certainty, then you have a clinical guideline and you can just follow it. We might agree that hyperacute stroke unit is a good idea, but we might definitely agree that it should be my hospital, not somebody else's. So we have, and then we have high agreement and low certainty. We're all agreed that you shouldn't wait very long in an ED department, but we're not quite sure how to actually make that happen. So It turns out, unfortunately, that an awful lot of our decisions are in this sort of zone of complexity in the middle. We're uncertain about about the causation that makes things happen, and we're not necessarily agreed always on what we're actually trying to do. So there's very high levels of complexity, and the real risk here is actually using the tools from the simple rational bit at the bottom. So, and then trying to apply those to more complex things. I think one of the wrong lessons we've taken from the healthcare-acquired infection reduction that we've done is that was a quite simple list of things that didn't affect the rest of the operation of the hospital and could just be put in place. So you need a different repertoire of muddling through, of experimentation, of short cycle change, and there's an area where you do political decision making, and this is all exacerbated by scale. And the NHS is unusual in the extent to which it's an international system which is run at the scale of 55 million people. It's just not something you tend to find in other places. And scale will increase complexity. It obscures local information. It flattens heterogeneity. It ignores local context. And that's why other European systems that seem to work do seem to be better at 1 to 5 million rather than 55. So very quickly, because I'm nearly out of time, but some bits of solutions. Well, first of all, some better questions and better diagnosis might be important. More rigor in testing the questions that we're posing, and in particular, fighting the emergence of groupthink. More critical thinking about the solutions as well, and in doing that, probably we would be better off to have a more diversity of disciplines and views. There's more to do to bring ideas from social anthropology, sociology, political science, organisational psychology, and even geography, which the NHS is notably very bad at. It has the approach to geography of the British Empire in the Middle East around 1920, which is drawing lines on maps that don't seem to work terribly well. Some of these people will need help translating what they write for the audiences in policy and management, however, because some of them do seem to be very keen on obscurity. I think, and we're very interested in this, and we'll talk about it a bit later, much more use of history and comparative analysis and getting much better at learning from the past, which we've been notably poor at doing, as I said before. Better policy evaluation might be a good idea. More experimentation, appropriate devolution and clearer decision rights, designing better support for implementation, and really tricky, understanding context. And the problem here is that a lot of the literature on context isn't terribly helpful. You get frameworks like Pettigrew and Whip's one, which are all perfectly good lists, although the arrows may be as important as the boxes in many of the conversations we have. So better understanding of this. And Mary Dixon Woods argues that to do this, we actually probably need better types of knowledge. So she rather impressively wheels out some ancient Greek. So she says we have episteme, standard book learning knowledge, techne, the technical ability to do it. But she then says, well, actually what you also need is practical wisdom and conjectural knowledge and cunning. And we probably need more of that. Short, digestible synthesis of the evidence. Even your mum is not going to read your 700-page report. She might skip the methods. So bringing all of these approaches together should increase the chance that policy will work better. And I think there's a big role for those of us who are sort of engaged in this process to try and bring better evidence, combat groupthink, make sure that people are using the evidence, test that the solution fits the problems, use some of this practical wisdom, particularly drawn from people from the front line. And so I guess if we did some of that, we might not, to quote David Nicholson, be able to see the results from space, but we might get some better results closer to home. Thank you very much.
Nigel, that's great. Thanks very much indeed. Just about to open it out, but I very carefully did not know what Nigel was going to say. And I was sitting there last night thinking, so what would I list as successes rather than going through all the failures? And I sort of came up with, well, day surgery, interventional radiology, vaccination programs, old and new. And these are almost all clinical changes that have happened because medicine has changed rather than because somebody's devised a policy, except when you get to a vaccination programme, there has to be a decision there's going to be a national vaccination programme, so the policymakers do get involved. But it's changing medicine that has a lot of the successes, rather than attempts to alter policy and structure. So we've got lots of time to talk about this. Let's,
our panel.
well, we are distributing microphones.
Where's our panel?
Thank you very much, Claire Gerardo, GP. Fabulous talk, as ever. But there's two things you didn't mention for the disastrous, which now have seen it so many times, which is to implement a policy, which might be a good policy, and then at some point just pull it out and try and see whether it's working, and then try and stuff it back in again. In other words, not even allowing the policy to get on. And the other one is the habit of having a fabulous service or a fabulous system and then smashing it up to pieces, or putting it out for tender, which is the equivalent of smashing it up to pieces, which we again do incredibly well in the NHS, and destroy good services that have been running.
Right, so we're not up here, do we?
Yes, you need your panel, Nick.
Very
We've
nice.
lost our panel.
We have a panel. I didn't
Where have they
know what
gone?
told me we had a panel. So can we have David Oliver that you're staying with Sally Warren, please?
That's a great point.
I was going to say, maybe better briefing would help as a policy. So, why not in order? Speak.
Okay, great.
Around that way.
So, brilliant. Good morning, everybody. I'm Sally Warren, Director of Policy at the King's Fund. And I suppose I have three reflections on what Nigel talked through. The first is to say, Nigel talked about 40 years of health policy. I'm 41. I was quite a precocious one-year-old, but I wasn't paying that much attention to health policy as a one-year-old. But I do have 20 years of experience, mainly in the health and care sector, but actually, quite importantly, a couple of times where I've stepped out of health and care, working in the Cabinet Office, and more recently in DEFRA. So one of my reflections will be about what we can learn from outside the health sector. So I suppose my first reflection would be it's really easy to focus on the failures. It's where you can get the giggles. It's where we can kind of feel that that's a unifying feature, is the frustration with that. But I would reflect on some of the successes. I think some of those successes are complex, but I think the fact that they have been successful has kind of meant that we've forgotten the complexity of what it took to come up with the policy and implement them. And in particular, I'd highlight some of the population health successes, which have been some of the main things that have really shifted in the last 20 years, which have been complex, but they've required quite a different type of delivery. So they've not been complex because we're changing NHS structures or payment systems, but we're trying to change people's behaviours. So teenage pregnancies, the reductions in health inequalities in the 2000s, all of that took a really complex set of change, but slightly different to really complex NHS system change. I think my other reflection is, as I was listening to Nigel, I was thinking how much of this is just relevant to any public policy and how much is quite specific and unique to the NHS and health generally. And the vast majority is pretty general to any public policy. You'd see rooms full of lots of other, be them BEIS civil servants, environmental civil servants, all grappling with the same issues around poor implementation, optimism bias, groupthink, etc. So I was thinking, what is it that might be particularly unique about the health sector when we think about policy and how we can improve policy and improve implementation? And from my point of view, it is actually the shadow of the NHS. So the NHS is a fantastic institution, it's brilliant, and quite rightly our politicians and our public are extremely proud of it. But it does therefore cast quite a big shadow over how we approach policy. And I think of those shadows in slightly different ways. The first is it's too easy for us to default to talking about healthcare systems rather than health. So we tend to lurch towards what's comfortable, but in doing that rather than what might be more challenging, thinking about health. The second is it can be really hard for us to talk honestly with ourselves, with our political leaders and with the public about some of the weaknesses in the NHS, because it's such a revered institution. Even suggesting it might not be perfect can be seen to be kind of fundamentally undermining, and you no longer believe in the NHS. So how can we talk honestly about its weaknesses? And then the third area is I think that we can think that the NHS is unique, and therefore we don't necessarily look outside to other sectors and what we can learn. And as Nigel was going through some of the examples, I thought what was quite striking is that where we did seek examples from outside the sector, not all of them successful, obviously, it's tended to be the politicians that have looked outside, not the public service leaders and the civil servants. So is there more we can do to have the system look outside to other sectors, to other kind of horizons and contexts to be able to learn from that as well? That's my reflection.
Sally, thanks very much indeed. David Oliver.
Okay, hi. I couldn't help noting that Matt Hancock yesterday came up with a nice template for what to do about bad policy when he was talking about coronavirus, which was contain, delay, research and mitigate until the next pandemic of bad policy comes down the line. And I've had an interesting ringside seat to a lot of this because I've been 31 years an NHS doctor, 22 as a consultant, but during that time of being shop floor clinician, I worked in the old Department of Health, actually in Sally's department, at the tail end of the Labour government and the start of the coalition government. So I've seen policy making and influencing from the inside. I've tried to influence it from the outside as BGS president and vice president of the Royal College of Physicians. And then more latterly, I've commented on it as a medical writer and working for the King's Fund. But throughout that, I've had the lived reality on the shop floor of what the impact of policy on what happens to patients. And I think one important thing is there is a huge disconnect between the policy wonk community and the shop floor clinicians. I could ask the nurses I work with the name of the chief nurse for England, or the doctors I work with the name of even the NHS chief exec, let alone the medical director, and they wouldn't know who they were really. And they certainly wouldn't have heard all the buzz phrases about cost improvement programs and control totals and asset-based approaches. So I think there's a real need for the people who are policy making to engage with frontline practitioners. And if you see what's happened with, for instance, the GP contract, it seems to have been an afterthought that the BMA might not be very happy with what it contained, and they might need to do some engagement at that point. So I think Nigel's point about retrofitting policies is very important. And certainly when I was working in the government, ministers would announce things, and then all the officials would be scrambling to try and put some flesh on the bones. In our briefing, we were asked 3 questions. I'll touch on them quickly. One is policies that I've been involved with directly or indirectly that worked well. The national programme around improving the care for people with hip fractures, clinically led, linked to national clinical audit, a community of improvement, and best practice tariffs has delivered. Much the same has happened for stroke, which I'm not directly responsible for, but clinically led, with standards that are credible to the front line and big data sets and sustainability. The British Geriatric Society has done a lot of work getting care home medicine on the map, the healthcare needs of care home residents. And Nigel and I, about 2013, were trying to influence the NHS 5-year view, and the care home new models, because there was a set of well-referenced resources about what good looked like, that has gone into the system architecture. And another one is the focus on acute frailty. There is now a big focus on zero-day admissions, front-door assessment of frail older people, an acute frailty network, a load of guidance tools. I would say to an extent, the focus on patient flow and internal delays, and to an extent some aspects of the National Dementia Strategy. There's certainly been a big focus on improving inpatient dementia care. Bad stuff, the single assessment process for older people in the National Service Framework. And I'm not criticising my predecessor as the NCD, but it was very confused. And the NSF for older people, unlike the ones for stroke, heart disease, cancer, didn't really come with any resources. I spent about 3 years trying to stop Andrew Lansley's policy of not paying hospitals for readmission. It reminded me of Max Bialystock in The Producers, where he said, I invented theatre in the square, nobody had a good seat. Everybody in the health and social care community thought this was a bad idea, but he announced it, and then we had to retrofit it. And the other one that Sally may remember is that when Andrew Lansley said we wanted outcomes and not politically motivated process targets, then the officials in the DH were tasked with producing an outcomes framework for public health, social care, and healthcare within about 3 months. And all they could do was cut and paste the existing outcomes. And it's not been any use to drive change at all. The failure to implement either DILNOT or the Royal Commission on Long-Term Care. I think there's one important thing here, which is sins of omission, isn't there? It's what we failed to do. And the 2 signal things we failed to do in my career are proper workforce planning. It's hardly a bloody surprise, is it? A lot of the workforce would want to go less than full-time, for instance. It's hardly a surprise that immigration policy might influence the workforce. We failed to plan, and we've complacently relied on overseas staff. And the other one is the serial failure over 25 years to come up with meaningful solutions for social care. The Care Act, which Shelley was leading the writing of, was a good piece of legislation. The Dilnot Review is good, but we haven't backed it with concrete investment. The final thing we were asked to comment on was any quick advice for anybody about policy in the future. Heed the lessons of recent history about what hasn't worked. Again and again, we keep promising admission prevention, and anybody who knows anything about the evidence base will tell you you're not going to attenuate the flow of admissions into hospital, and it's not going to save money, but we keep promising it. So, you know, learn the lessons of history and base what you do on robust evidence, but most of all change will be subverted by the frontline professionals who are working in health and social care, and if you don't engage them right from the outset, then it won't work. And the reason things like hip fracture and stroke have worked is because the professionals were on board right from the outset and defining the standards. So I think that's the signal error, is to get that disconnect between policy and frontline clinicians and operational managers. But right, thanks.
Great, thanks. Thea.
Right, so the joy of going third is, of course, I can say I agree with absolutely everything everybody else has said. And would have said those very wise things myself, obviously. But I'd like to add just a couple of thoughts to it. One is about detail. I think policymakers either forget incredibly important detail, which is about sometimes their inability to have actually walked in the shoes of being a jobbing chief exec, such as myself, or they obsess about detail and get lost in it. And so, for example, I'd like to use two recent examples. I think in the creation of one of my genuinely policy that I love at the moment, which is primary care networks, and equally hate at the moment because of its complexity and what I'm trying to do, there seems to be no conversation about the fact that primary care are outside the NHS and they do not employ staff on NHS terms and conditions. Just a little detail, tiny, weeny detail. That means that in Leeds, where I work, where I have 19 PCNs I'm working with and supporting, that will be recruiting over the next couple of years, 190 to 200 really skilled and important community clinicians could all not be on agenda for change conditions and will not be going into agencies where they're on continuity of service. Tiny, weeny detail. Second, you can obsess about detail. We can go down a rabbit hole of detail. So again, just from my current world, the aging well policy. Love it. 2-hour response. Well, I don't really love the idea of why 2 hours? Where's that come from? Haven't we learnt from 4 hours and all the excitement that brought us? But 2-hour community response, not the right community response in the right place at the right time for the right level of care. And there is already a conversation which is making me want to weep, which is when does the clock start for the 2 hours? If you're not involved in that conversation, I can only wish that you remain outside it, but it is making me want to weep. So you can obsess with detail, or you can forget detail. The second thing I want to say is we think that organizations and people in organizations create transformation and embed policy. And I couldn't be more with my colleagues who've talked about workforce and bringing clinicians and workforce with you. However, we also have to bring communities with you, and you have to bring the public with you, you have to bring the citizen, the patient, and real transformation, real change about how we care, for example, for our older, frail population will come from the way in which we bring our populations with us and understand the way that change is embedded rather than anything else. So I will stop there.
Good.
Yeah, thank you very much indeed. Do you want to respond to any of that before I open it out?
Let's ask the audience.
Yeah,
They were great points. I agree with all
I
of them.
just reinforce Sally's point that a lot of this stuff is not unique to the NHS. It's a public policy problem more generally. Hands up. Sorry, the lights are not great.
It's
I think
Nick
that's
Black.
Nick Black.
Yeah.
Thanks. Nick Black, London School of Hygiene. I think that there are lots of examples where centrally led policies have had a great influence over the last 40 years, and some of you have mentioned some of them, so did Nigel. But looking at the title of the session, what are the lessons to be learnt? The one lesson I take away, looking back over 40 years, all the ups and downs, successes and failures, is despite the best attempts by people in this room and our predecessors to try and devise policies at the centre. Despite that, on a Monday morning, every primary care centre, every hospital opens its doors and patients and in social care clients get managed on the whole, mostly in a pretty good way. That's not to underestimate the challenges the NHS and social care faces, which we're all familiar with. So the lesson is, despite the best attempts of policymakers, thank God the service is more resilient for the sorts of reasons that David, you were talking about, that clinicians actually get on with it despite the best attempts from the centre.
That's great.
Yeah. Although, as Claire was saying, that there are still hazards to that. The policy can reach in and cause problems. Yeah.
Yep. Andy Cowper.
Andy Cowper, HSJ and Health Policy Insight. What are the panel's reflections on the tipping point of trying to start to get a bad idea to either be understood as a bad idea or to die? I'm thinking particularly about some work which David and John Appleby and some other colleagues did on the HSJ's Commission on the Hospital Care for Frail Older People. I think we were among the first people to suggest that the policy of trying to reduce acute admissions and therefore the bed base was unlikely to bring success. And when we published that finding in 2014, it was seen as being slightly controversial. I think now it's probably not. What do the panel think is the way to achieve those sorts of tipping point moments?
Anyone have a view on that?
Well, that specific example, people who actually know stuff have been saying for years we can't continue to reduce the bed base. They've been saying for years that snapshot bed audits that tell you that people don't need to be in the beds are meaningless if you don't have the capacity in community services. The National Beds Inquiry in 2000 described the fact that unless we invested seriously in community alternatives, we couldn't keep losing beds. The College of Emergency Medicine have said it. The Nuffield Trust said it. That we needed the equivalent of 20 new DGHs by now, really. So it's not news, is it? I think the tipping point for the professionals is often the minute they hear the bloody announcement. And I think, but I'm really glad that Thea mentioned logistics, because logistics and risk registers and actually the flesh on the bones of how you implement these things in the workforce are often where they die, aren't they? But we could save ourselves a lot of bother if everything wasn't driven by ministerial vanity and the electoral cycle, because what we know realistically about the pace of change is it's going to take longer than 2 or 3 years to produce something like even an attenuation in demand for hospital beds. So,
This is an interesting example because there's a strange process in which it appears that consensus emerges without you necessarily, a bit like the way that jokes appear simultaneously, or that Leibniz and Newton invented calculus separately. There's sort of, it's almost like there are things in the air and that. I'm not sure about morphic resonance. That sounds slightly woo, but it does explain what happens. It is strange, and it makes it quite hard. You know, you plug away. I mean, there is Alistair Campbell used to say that you need to, the point at which you're so bored with what you're saying. That it's just the point where people are starting to listen, and it may well be that Chris Ham's 10-year "It's All About Integration" campaign is very successful. But I did wonder sometimes whether he wasn't starting to feel, God, I'm still saying this. And I think it's a kind of non-linear process. This emergence of a consensus and getting to a tipping point makes it quite hard to systematise and explain. But it probably, like Alistair Campbell said, just the point at which you're boring yourself and you're physically sick with saying it again is just the point at which you're starting to be listened to.
I think there's an important point with tipping point, 2 points there, on it's because of groupthink. So in effect, how can you make sure during the policy and implementation process you're staying open to hearing lots of different voices at different points in the spectrum and not assuming motivation for what that spectrum is? Because I think we can too often have well, of course the doctors are saying that because we're about to negotiate a new contract with them, or of course and we kind of ascribe motivation without really understanding the reason they're saying that is because their frontline clinical experience would suggest it's not that straightforward. We've synthesized the evidence in the wrong way and it's leading us in the wrong direction. So how we can create conversations where disagreements are not just aired but properly understood requires a different way for us to have conversations and dialogue and engagement, but that's the only way to really start to understand that divergence and kind of cut through it.
Great.
There's Nick Mays and
One over there.
Andy, is it? Andy Bell?
Hi, Andy Bell from Centre for Mental Health. Gosh, this is a big room. One of the things about working in mental health is we have an overlap of our own policies and also those of the wider NHS and health policy, and so it feels a bit federal. Perhaps we feel a bit like Britain in Europe before this year. And so we've got kind of two things often which don't align with one another and sometimes go in completely opposite directions. When we had a look at the last 20 years of mental health policies, we couldn't find one that had been independently evaluated. And I guess my interest is, what would good evaluation of policy look like? Because I think because it tends to be so political, it tends to be so politicized, we evaluate all sorts of things apart from those which really direct things. So what do the panel think good would look like? And how can we perhaps have greater alignment? Because I'm sure lots of other sectors have similar experiences.
Do we want to deal with that at the moment, or take?
Give us a minute to think about that one. Find us an
Let's
easier
go.
question, for goodness sake. We'll come back to that, yeah. And there's Nick Mays, yeah.
Yep.
Nick Mace, London School of Hygiene. This is really a comment, so you might want to turn it into a question, and it relates to one aspect which is probably endemic across public policy, which is churn and turnover among civil servants. Going back to you showed a picture of Clive Smee at the beginning of the session, and of course Clive was 17 years in the Department of Health, and he represented in a sense the antithesis of that, which is continuity. It seems to me that given that we have short electoral cycles and we have ministerial churn, there's absolutely no point chiding ministers for wanting to make announcements. But it does seem to me one of the skills of civil service and developing continuity is to always be able to have a repertoire of policy solutions in search of a minister who wants to make an announcement. In other words, a serious point, which is that if rather than being shocked and put on the back foot or having to do damage limitation when a crazy idea comes in through the SPAD sort of system, you actually, I mean, one of the tricks will be, I think, to be able to have some things that you've really wanted to do which you can understand and you've got some evidence base or some clinical engagement and you can make it available. And that was something that Clive did from time to time, particularly found a junior minister who needed to do something to bolster their career. So turning essentially what could be a problem into a partial solution. But it doesn't require continuity and expertise inside the system.
Yeah. Great point. Should just respond to Andy's point, because there is actually a whole load of method and approaches for doing policy evaluation. The problem is not knowing how to do it. The problem is wanting to commission it and then wanting to publish the results. And I remember a story of one special advisor sitting on Sally Davis's desk, shouting at her about the temerity to actually evaluate a policy that his minister had put in place, and trying to stop her from publishing it. You can probably, those of you who know Sally will probably be able to work out how that encounter ended. But I don't think method is our problem. Actually, it's a problem of will.
Do you agree with that?
Yes, but I think I'd also expand it to say I think too often with evaluation we consider that scheme to be unique, and we're cleverer, brighter, we're not going to fall in the same trap. So there's a bit about how we are all capable of engaging with the messages from evaluation and being quite honest about ourselves and how we're leading in that space. So I think it's not just how you evaluate, but how you learn from the evaluation.
That's good.
I also just wonder, as the kind of person who's been a civil servant for 18 years on the panel, whether I should just kind of comment on Nick's point. So a few kind of different reflections. One to say is that churn isn't always a bad thing. So healthcare-acquired infections is considered one of the successes of the last 20 years. I got moved onto that policy and delivery area at 24 hours notice, having had nothing to do with it at all in my career and know nothing about it. It didn't stop it being a success. I think I helped it rather than hindered it from a churn point of view. But there is a lot overall of churn, and I think the key bit becomes organisational memory and can you learn from it. So a lot of civil servants, we will have that list of these are the policies. So if we take social care for an example, it's a long failure. There's only so many ways you can solve social care funding reform. It's not that every new team team starts from scratch. Every new team is kind of learning from what's happened before, and I spend quite a lot of my time trying to explain from my perspective what's happened over the last 10 years with social care reform, what's worked, what hasn't, and I do quite a lot of that privately to help people not create the same mistakes again. So I think there is more of a willingness to learn, but some churn is good, it creates new ideas. Too much churn is bad because you don't have enough expertise and enough memory.
Can I come in? I think there's also, we're obviously talking, and this is a very eminent room where we're talking about things on a national level. As somebody who's worked at a national level, but also a lot at regional and local level, I think you shouldn't underestimate the power to shape policy from the bottom up or from that local level. And I would agree with the idea of having ideas, having schemes that are ready. Working now at a local or regional level, we'll always have schemes ready to influence those who are around us, around the way in which it's commissioned or the way in which a policy is implemented. And that's the way in which a policy and the actual implementation on the ground gets shaped by the way in which you also use evidence. I think one of my frustrations often is the lack of discussion of evidence within the chief exec leadership community. This is absolutely not saying that it isn't there or trying to be different from, but I don't think that there is enough conversation about our ability as a group to use evidence to both lobby and frame the way in which assessment and evaluation of policy on the ground is done, the scale in which it's done, the time frame in which it's done on, or indeed the intellectual framing of what it is that we're doing. And I don't think it's encouraged, but I think that there's some space that we as a community should be seizing to do that better.
Just before I come to you, just partly pick up on that. If you look at some of the successful policies, I think everyone would class NICE as a successful policy. And that was actually an odd mix of bottom-up and top-down. So, before NICE, there were the regional DECs, the evaluation committees that the regions started inventing because people needed to know what to buy in this new market and whether it was worth it. And then you had Clive Smee, who sort of took 6 weeks off and went around America, New Zealand, and Australia, and came back and said, we're off the pace in evaluating cost effectiveness of pharmaceuticals. So you've got some stuff that's coming up from the bottom because there's a clinical commissioning need for it, and stuff that's coming down from international evidence, and it all sort of begins to come together, and you get something that works. David.
Well, one quick resource to mention, I don't know if Chris Whitty's here, but I commend to you all a paper he wrote in 2015, I think it was, called What Would Make a Scientific Paper Useful to Policymakers, which explained really nicely why often the academic cycle is too slow for the policymakers. But I think the answer is, of course, there is a well-established methodology for policy evaluation, and the three main health think tanks do it, and academic departments of health service research do it. My question is whether anybody in government or national bodies really cares about what the findings are. And I think there's ample evidence that people repeatedly fail to learn it. And there's just one example I didn't mention that I think illustrates the problems, which is the fixation over the past decade with telehealth and telecare and digital healthcare solutions. Lansley announced that 3 million lives, no idea where he got this figure from, would be affected by telehealth and telecare. Then senior officials in the Department of Health were saying, now we know that it works. There's no excuse not to roll it out. And then when the government commissioned evaluation, Whole Systems Demonstrator, was published, the results were completely null. There is a nice framework for evaluating new technology, but again, in the creation of NHSX, there doesn't seem any particular interest in objective, empirical, peer-reviewed evidence. What was been described as digital exceptionalism, really, that the normal rules don't apply to digital. And that's why you get a company like Babylon Health getting more and more market share with government backing, or people making massive assumptions about automation and robotics transforming the healthcare and requiring less workforce. You don't see the workings, you don't see the numbers, there's no peer-reviewed evaluation, but the policy's still pushed. So I think my question is, using that as an example, is anybody that bothered about the objective independent evaluation? I suspect not.
You just have to believe, David.
It's a cult.
You just got to believe.
It's a cult, yeah.
There was a hand up, 2 hands up there. Can we take those two together, one after the other?
Thank you. Crystal Oldman, and I'm Chief Executive of the Queen's Nursing Institute. My question's about nursing and nurses' involvement in policy. It's really interesting that there's been a kind of theme of it's really important to engage with the front line. The front line will inform policy. Now, nurses make up 40% of the workforce. 50% of them don't work in the NHS, so they're really good at informing around health, social care, the charitable sector, education, etc. So my question is about how do we systematically involve nurses in policy and policy development? One of the things that we do at the Q&I is to engage with those two things in terms of policy development in engagement is to ask those who are developing the policy to come and spend time working on the shadowing on the front line. That has been really impactful, including Prime Minister's special advisor. Feedback, that was the most impactful day I have ever had when he spent the day with a district nurse. So that kind of frontline informing policy, it's great, we can do it on an ad hoc basis, but how do we get systematic informing policy in a systematic way from those who make up 40% of the workforce and spend the most time with the citizens that we're supporting?
Right. Would you like to do those two together?
Thanks. Anne-Marie Rafferty, President of the Royal College of Nursing. My question was also similar to Crystal, so I'll think of a different one, which is that I guess on the question of churn in policy and the circulation of civil servants, I think they often carry ideas from one department to another, and I think that policy transfer and translational process is partly itself responsible for churn. But many of the, I think all of the panel members and speakers have referred to workforce as being one of the things that gets left behind. And I just wondered if there was a view from the panel that essentially, rather than being a last minute thought, that we should start from workforce and reverse engineer policy design and all of the implementation and evaluation processes that should underpin it.
Would anyone like to pick up those points?
Shall I kick off? So in terms of systematic involvement of the front line, I think there's lots of different ways to do this, aren't there? So actually when Jeremy Hunt was Secretary of State at the department, he instituted all senior civil servants had to spend 5 days on the front line. And I think, to be fair, that was initially greeted with a bit of scepticism as me being a polite former civil servant. But actually it did help create connection and an understanding of reality on the front line in a way that some of us as patients might get, but it was slightly different when you're there kind of almost with your job badge on. There's also been lots of examples of organisations where they've kind of deliberately put in place processes or systems to do it. So I can see Andrea on the front table. So when we're at CQC, kind of having every month a co-production approach where we would have a room full of people who are either using services or delivering services to help challenge and shape our work. So there are lots of different ways to do it. Some of the issue is about pace. So ministers wanting to kind of move really quickly can be a real issue about how do you have it be genuine co-production engagement and not a token. Then just reflection on churn and should we start with workforce? I mean, I guess maybe slightly a challenge back. Shouldn't we start with patients and the public and what they want and need from their health system? And then you work back from that. But I think too often patients and the public definitely aren't at the heart of what's driving decisions, and certainly workforce isn't. So I think there is something about how do you turn things on its head. But I would put patients and the public up there rather than the workforce.
Okay. Well, there's a lot of very eminent nurses at that table, and I think you've probably got the solutions yourself, especially some workforce experts there. So far be it from me to say how nurses particularly should be engaged. But I think, I've hosted a lot of senior officials and SPADs and think tank people actually, and some ministers spending a day with me in the service, and they do all come away having that grounded sense of how some of the policy impacts. I don't know how much good it does in the long run, but I think it is a useful thing to do. I think the question about should we start with the workforce, I think what we need to do is think about what is the core purpose of a national publicly funded, publicly provided, free at point health service. What function should it be playing? And what should specifically be provided by a health service as opposed to wider societal policy? And having defined that, what are hospitals for, what's primary care for, then you need to design the workforce around that. And then you need to look at the role of teams, about role flexibility, role substitution. Should people be working at the top of their pay grade where they're adding the most value, or should whichever member of the team has the right skills? And I don't think any of that's been done in a systematic way. But we're talking about just incompetence here, aren't we? Policies being announced where nobody has thought about the workforce implications at all. And even if you look at primary care networks, which I think are a good idea in principle, those occupational therapists and paramedic practitioners and physiotherapists, nurse practitioners have to come from somewhere, and we've already got epic workforce gaps, and if they're taken into the PCNs, then they're going to deplete local community health services, and that policy has been favoured over some other bits of the plan. So I think logistics and risk register and workforce have to be built into any bit of policy. And I think that's why I was glad that Thea mentioned logistics and feasibility right at the outset. There is an issue about bottom-up policy. You can see some things in the plan have been driven by clinical leaders. PCNs are basically primary care home, for instance, or the work on nursing homes. But there's an interesting thing about how come some initiatives catch the eye of SPADs or ministers, and something else like the fact we've got about half the number of district nurses now that we had a decade ago don't seem to be on the radar despite all the campaigning. I don't have the answer to that one.
So we have a theory that slow burn issues are harder to spot, and this afternoon session is going to explore the fact that when we actually discovered we had a workforce crisis, if you look back, we've been talking about having a workforce crisis for it wasn't really a surprise, it was hidden in plain sight. Yeah. And healthcare acquired infection was a similar thing. I mean, it was well known. Everyone said, oh, it's normal, nothing you can do about it. Falls would be another one, actually, where these problems suddenly, and it's part of this mysterious group, sort of positive group thing, where suddenly people go, oh, actually, this is a big problem and we should do something about it. And I don't think we understand how that happens. So this afternoon, one of the things we can try and do is work out what are those other things that we're sort of are hidden in plain sight, which are sneaking up on us.
It's making me think of I heard Chief Medical Officer of Scotland many years ago talk about if we saw public health crises or some of these crises as a fire, as literally as a fire, we would see them. Yeah. And of course, when we've seen Australia on fire, I think for a lot of people, the reality of certain things came home to them because you literally saw it. And that we see these problems like district nursing, which is clearly very close to my heart, creeping up, and you only get to a certain point, you go, oh my God, it's huge. Yes. And it's like, yeah, we've been telling you for years. But I do think there is a sweet spot, going back to those questions, which is about how you use the public and how you use workforce together, because we mustn't also over sort of sentimentalise our workforce and their ability to change. A lot of our workforce are quite conservative in their views, very difficult to challenge, very difficult to change, find it hard to go along pathways towards really inspirational futures. And a sweet spot is often where you get really good people from the public, you get really good users and carers, you get really good staff together with policymakers, and you develop it all together. But that's much harder than just having a good idea and going with it.
Yep.
Can I also just build from that point about language and kind of community? So there's a slight risk that how people are talking about policymakers in the room, they are talking about a special group of people who sit in Victoria Street or in Skipton House. They sit at a desk and write submissions and go and speak to special advisors or ministers. I guess my challenge to all of you is you are all policymakers. You might not be civil servants, you might not write the submission, but you're policymakers. And unless we collectively recognise, yes, absolutely the pressures you're under in terms of delivering your day job, but also the realities of how civil servants need to engage with the political system and engage with SPADs. We can't have this be an us and them thing, that it's we're all great and we know how to do good policy, it's the civil servants and the public servants that don't. So I just think there's a bit about how we can recognise we are all in this and we all bring different skills and insight to the table.
Right, we've got about a quarter of an hour left. Can I pick up some hands that have been up in order, so to speak? So Peter Smith back there, and then Rebecca Rosen. I'll come to the front again later.
Thanks. Peter Smith, health economist. Sorry, I've just realised I'm listening to myself. So I just wanted to develop one issue which I think is a peculiarity of the English national health system, and that is the reluctance to look overseas even as far as Scotland, in looking for policy alternatives, policy successes and failures. And I was struck, I was involved in teaching a master's programme to many of the students were early and middle career civil servants from the health department. And in the first week, we used to introduce a website run by the European Observatory on Health Systems, which had a huge synthesis of evidence from across Europe and beyond on health policy. And it was remarkable that almost none of those people who had been in post, many of them for a long time, how few of them knew of that website and how few of them actually had engaged with experience overseas. So I just wonder whether there's something peculiar in the UK, and specifically in England, that stops us looking for these really innovative solutions that can emerge from overseas, and maybe not running into some of the traps that we run into by being so blinkered and self-absorbed.
Yeah. Rebecca.
Rebecca Rosen from the Nuffield Trust and also a GP in South East London. I want to reiterate the question that Claire asked right at the end of her first thing, which was we have a tendency to implement policies nationally and uniformly, and in doing so, quite often undo services that have been set up that are running incredibly well, quite often with a proven track record and good outcomes, and we just dismantle them because of the narrative of we have to do this and simplify it and once for England and all the rest of it. And I just want to know the panel's opinion about what they think about that, because with my clinical hat on, there is very little more demotivating than having an excellent service. Our example was integrated health visitors working with us in the practice across a community of 30,000 with exceptionally good and improving outcomes. Suddenly dismantled. It is so demotivating.
Yeah. Would you, I mean,
Well,
anyway,
I feel
those two
being,
questions
you know,
interact quite
as
nicely.
Chief Executive of Community Trust, I have spent many, many years having brilliant services decommissioned and recommissioned. I went through the whole of the health visiting school nursing service being put out to tender and winning it, the whole of the IAP service being put out to tender, re-winning it, family practitioner nurses. So I absolutely agree that there is a real problem with that. There also can be a real challenge in a good challenge as part of it, if it's done well, but I think there is a reluctance often to look at the evidence of what's going well. We're talking about public health as well, and then you get into the local authority commissioning rules and procurement rules and how they impact on all of that. But I think, yes, broadly, it's definitely something that we suffer from and don't learn from where things are going well. Just in terms of not looking overseas, I think there's also the other part, which is that the English system gets obsessed with certain models from overseas. There was a certain time when you couldn't go anywhere without hearing about Kaiser Permanente. Yep. You know, and that was going to be the answer to absolutely everything. Or NUCA, which actually I like NUCA, I think it's lovely. Or the New York system, etc. So you get to certain points where there are certain models which we seem to get obsessed with, as well as not looking at all. We seem to do one or the other.
Yeah. So I think several think tanks are guilty of doing shiny reports on some of those international models, so conflict of interest here. I think there is a really interesting point about where we do look overseas. It tends to be Australia, Canada, the US. We don't actually look across the United Kingdom very much. There are one or two exceptions, but more often than not, we don't. That's sometimes because we say, oh, but Scotland's gone down a different route on integration, so we can't really learn from them, as opposed to going, well, why have they gone down that route and what might we be able to take from it? So I think the kind of England versus the UK bit is something that when I was in the department, I sort of didn't really notice that we focused just on England. But then when I moved to DEFRA, and we were kind of, barely a day went by when I wasn't talking to counterparts in Wales, Northern Ireland or Scotland. It was, for me, quite an interesting kind of really bringing into sharp focus that we have traditionally focused on England only and not reached out to learn from our colleagues across the UK.
Yeah, can I just observe on that? The problem with the three-way comparison in the UK is the politicians don't want it. because they're terrified of the answer. And, you know, on both sides of the border, they don't really want to know whether something is going better in England than it is in Scotland, because it gets in the way. So actually, well, Nick Mays knows more about this than I do, but if you want to do this stuff, you need comparative data, and the data has been becoming more diverse, not more in common, since devolution. So it gets harder to do.
So on those, right, the thing about devolved nations, it's useful to, you might argue Scotland's slightly outperforming the other three nations, you might argue that. But what's striking is all four systems are facing the same set of wicked problems about demand and demography and workforce and overcrowding, despite the others not having a purchaser-provider split or not having the same financial instruments, which kind of makes you wonder how much of an influence policy has over some of this stuff, because they're actually universal challenges. And maybe, for instance, if we had enough beds or we funded social care properly, we didn't have the lowest number of nurses and doctors per 1,000 in the whole OECD, along with Ireland, that would be more use than obsessing about policy. But I think Rebecca's point is well taken. Rural and remote communities have very different challenges to big urban areas, for instance, and you don't want to be imposing a one-size-fits-all solution. And actually, one thing Lansley had right when he came into the DH clear-eyed, I think, was that if we focus more on outcomes and not on processes, that was the right way to go. And I'll give you one example. Imposing, I can't say anything here without offending half the people in the room, I realise, but I'll do it. Imposing GP streaming onto every emergency department in the country because it worked in Luton.
Luton.
Yeah, exactly. Yeah. That's not useful, is it? Because actually, when it's been properly evaluated, and there are two big NIHR studies ongoing now, it doesn't really work. What you should do is say, here are some key principles of what good looks like early senior assessment when people arrive in the emergency department, and then let people devise some local solutions and evaluate them properly. I spoke to one well-known chief exec here last year, and he said, well, whatever comes out in the 10-year plan, we'll kind of do what we need to do to feed the beast and demonstrate we're doing it, but then we'll do our own thing anyway. And I think that does happen. But we shouldn't be imposing templates on health economies that have already got stuff right. We should focus on the outcomes and the key bits of the process and let them do some local service design. I don't think we've got that right.
And that would, to some extent, deal with the problem that Rebecca and Claire had mentioned of having to impose a model that is you'd be able to say, well, I'm achieving the objectives of the model. But I've done it by adapting the principles, and you know, I've replicated the principles, but I've not necessarily cookie-cutted the policy. So regional tiers so in Spain, for example, the autonomous community, to be international for a minute, autonomous communities run their own health systems and have large amounts of latitude to develop their own solutions locally. And some of the better, we've just been doing a bit of a history of the last years of regions and the SHA period, and the ones that again did that well, they didn't block national policy, but they took an intelligent approach to its interpretation and local implementation. And I think having some system to provide a bit of a block on the you have to do it this way because you know the policy says you must, rather than because there's a good evidence base for it and it fits your local context. It did actually sometimes have quite a useful role, and when they went, sometimes we understood what we'd missed. The observatory, for which, by the way, the Nuffield Trust is the UK correspondent, is a great repository of this. But you're quite right. The department, although the Department of Health do actually sponsor that, they are very, very uninterested, both in Scotland and Wales. And the only interest I've ever had from a national politician in Wales was a surreptitious attempt to get a briefing on how bad it was for use for political purposes rather than for learning. So I think there's more comparative studies of different countries, and particularly in Europe, actually, would be really quite helpful.
I think it's just also worth saying that, again, it's different in different policies. So actually, in social care, I think there is much more interest from politicians and policymakers to understand what's Wales doing, Scotland, Germany, France. It's something about our healthcare system where we don't seem to look north of not quite north of Watford, but
just picking up one of your bits in your earlier presentation about theory of change and picking up on Claire's point. I have slightly fond memories of the early days of the Modernisation Agency, when it was trying to help hospitals do the 4-hour A&E work.
Yes.
When it would go in and say, not this is how you do it, it would go in and say, here's a clutch of tools that other people have used that have worked for them. So you have a look at them and try and work out what would work for you, because your problems won't be identical to everybody else's. And people engage with that and owned the solution because they'd chosen how they were going to do it, and they did adapt things. But it was quite an effective change mechanism, because it didn't say there's one size fits all and here you go. You know, you work out which of these things that have been useful elsewhere will be useful to you.
Yeah.
We've got time for about 2 more questions. Can we come down the front here and hand over there?
Both called James. Yeah.
Yep.
Ingrid Wolf, Evelina London, Children's Hospital and King's College London. My question is about the tipping point for policy, and I wonder if we have reached such a tipping point for patient-centred care, which seems to elude us at all times, certainly child-centred care, and it seems to exemplify quite a lot of the challenges that Nigel and others have presented this morning.
Should we take the second one?
Great. Thank you. James Morrow, GP and Cambridgeshire and Peterborough STP Board. In Cambridgeshire and Peterborough, we're living with one of the biggest national deficits. About 50 million of our structural deficit is due to perhaps failed policy decisions historically. Nigel's forensically dissected why policies may fail. The panel have elucidated evidence of policy failures. And I suppose in a slightly light-hearted way, I'd like to know what punishment the panel think is appropriate for people who fail to learn from history and repeat the mistakes of the past as policy decisions.
So I'll start with that, because it goes back to my point about collective responsibility. You're all policymakers. You're not passive people who receive directive from above. So what punishment would you like us all to collectively receive? We can all not have lunch today. We can be forced to work. But I think this is what I'm starting to say. This concept of there's a group of people sat in an ivory tower and it's all their fault is not going to help us move on from here and really address the challenges we have across health and social care. So we've all got to start to recognise we've got to work in a different way, learn to listen to each other in a different way, and not do a kind of penalise and punish and blame, because in the same way that we're saying we want a culture where we don't blame clinicians, we certainly don't want a culture where we have civil servants who feel they can't speak the truth to the sector or to ministers for fear of being punished by the people sat around this room. So I'm not particularly liking some of the kind of sentiment that's sitting behind some of this sense of there's a group of people whose fault it is and the rest of us are angels.
I think there's an interaction between what you're saying around speaking truth to power, because I think in order to create culture, because I agree with you. I agree I'm a policymaker. I raised it, that we're policymakers from the ground up. But I think that there is a culture, and it's been talked about a lot by people who are trying to change culture like Prana and others, that there isn't a culture of honesty, openness, and the ability to speak truth to power. I think there's often rooms where people feel scared to talk, both to ministers, both to leaders, both to policymakers, even at very senior levels, where there is a fear of, oh, that will be, they'll say, that's not going to be good for my career. So I think there's something we have to do in order to create the environment where what we all need to do is learn and feel powerful. We have to feel confident in the room that speaking truth to power will not be career limiting in any way as well. So I think they go together. Yeah.
Well, Sally's right, of course. Cultural blame is not going to help anybody. Because we have an almost uniquely centralised, politically accountable system, inevitably lots of blame is directed at ministers and officials and senior people in non-departmental bodies in a way that wouldn't be the case in countries where there's more devolution to local managers. The person-centred care tipping point, I think if you were to go back in fact, when Nigel asked the question, my challenge back was, if we were to go back 10 or 15 years, which bits of how things were like then would we want to re-embrace? Because actually a lot of things have got better. People were not talking about person-centred care, patient-reported outcome and experience measures, shared care and so forth in the way that we are now. So there's a lot of awareness, there's a lot of talk, there's a lot of focus on it. Is it a lived reality for most people using services? And such evidence as we have mean we've got a fair way to go. And I think a lot of the reason is because of the wicked problems we talked about. There's a hierarchy of priorities, isn't there? And if, as a hospital doctor working in acute care, it's getting people out of the beds as soon as possible, not having overcrowding in the emergency department, trying to take the least risky option and keeping people flowing through the system. And in something like that, you're going to lose some of that low-key stuff that really matters to people and their families, especially when 1 in 8 nursing vacancies is unfilled. So I think it's the right direction of travel, but to do it better, it does keep coming back to more resource and more staff so they can actually focus on that. I've got a 28-bedded ward, and I have about 4 hours to get round it. If I happen to have my registrar with me, I can suddenly split the ward in half, and she can do half and I can do half, and I've actually got time to spend with people and I can have the conversations they want to have. If I'm on call in the acute medical unit, I will see 35 to 40 new patients in a 12-hour shift, right? Well, when you're seeing people at that pace, always with your eye on the clock about the next one, knowing that the hospital, which is rated outstanding, has still got 70 or 80 beds down at the start of every working day, something's going to give, isn't it? So I think the answer is to make person-centred care a reality. People need time, and we need to actually start paying as much heed to outcome measures that matter to patients as we do to things like 4 hours and financial control totals. And at the moment, we pay lip service to it.
Well, we've run out of time. I hope you think it's been a great session. Nigel, I'll not ask you to sum up.
Oh,
just
thank goodness for
thought
that.
you might like the last word.
Yes. So lots of great points. I mean, it is worth reflecting that we had a list of successes. There have been a lot more. Quite a lot of things do work. The system is significantly better than it was 20 years ago. Bits of it may have gone backwards a bit, but it's unrecognisable in some ways. So we should probably celebrate quite a bit of success. I think people made a lot of points about the need to have a much better understanding of the sort of granularity about the front line, about what you're imposing. And I did come back, the continued question that worries me when we do look internationally is about the scale and speed with which we try and do things, and actually going slowly in order to go fast. There was some Latin tag for it, I'm sure Boris would know. It's quite a good lesson here. The second, I think, has been a real interest of mine and something for many years, is getting the research community better at articulating things that will help the policymakers. Sally's point, I think, is a very important one, and one we should leave with it. It's just even the most unsuccessful policies were done by people with good intentions. We haven't got a problem of bad people. We have a problem of inadequate systems and support, perhaps over-ambition, either in terms of objective or speed. And we might proceed better if we were willing to question what we're doing a little bit more closely at the outset.
Great. Thank you very much, and thank you for your questions. And can you thank the panel for their contributions too? And there's coffee next door.